Okay, now it's live.
Okay, yeah, that looks like it's working. All right, and we're at 2 o'clock, so I guess whenever you guys are ready to go, and you can open the waiting room and start presenting.
Brian, would you like me to open the waiting room?
Yeah, that's fine. It's
Okay,
2 o'clock. Let's do it.
coming now.
All right. Okay, it's 2 o'clock, so let's get started now. Hi everyone and welcome. Thank you for joining us today. My name is Brian O'Donnell. I'm a DHIS2 implementer at the HISP Center at the University of Oslo. Today we'll be having a webinar on non-communicable disease data in national HMIS, rapid reviews from 4 countries. So we'll have representatives from 4 different DHIS2 countries talking about how they collect NCD data in their national health management information systems. Before we get started, I just wanted to set us up with a quick agenda. So first, we'll give a background and purpose. Then we'll go directly into the rapid reviews of the NCD data, and then we'll have wrap-up and acknowledgements afterwards. We will be taking questions between each country presentation. So if you have questions for the participants, go ahead and either raise your hand in the chat, or we put it in the chat for the Zoom link, or you can also go to the COP thread as well and drop your questions in there for them. I'm also going to start with just the world's fastest overview of NCD trends, just to put our presentations into context. So as many of you here know, due to global demographic changes and improved treatment for infectious diseases, the world is experiencing an increasing burden from non-communicable diseases in their health systems. This pattern is especially significant in Africa and other regions where NCD is frequently adopted, especially within overstretched health systems, adding an additional burden. Already, the WHO estimates that 80% of premature death from NCDs currently occurs in low and middle income countries. And if we look at disability adjusted life years, we see that NCD burden for the last quarter century has really increased globally and also regionally in Africa, as well as in every country that we'll see presented today. If we decompose this regional death rate and project them into the future as well, then we can see which NCD categories we're really talking about as pushing this transition. So by 2050, the top 5 causes of disease across sub-Saharan Africa, as well as every country presenting today, will include cardiovascular events, cancers, diabetes, and kidney diseases. But this shift is not just happening into the future, I should add, it's also happening right now. So should consider that by 2026, for example, cardiovascular diseases will replace respiratory infections and TB as the #1 cause of death in sub-Saharan Africa.
Brian, one moment, please. We're having messages that people are not able to see your slides or what you're sharing. Is there something you need to change on your end?
Um, oh, I will resume the sharing. Okay.
Thank you.
Right. Great. So this was just the background of the NCD trends and also talking about the decomposed death rates and projecting them to the future in sub-Saharan Africa. We can see which NCD categories are pushing this transition. So by 2026, cardiovascular diseases will replace respiratory infections as the #1 cause of death in sub-Saharan Africa. Moving on to the next slide. We can see that the world has made a strong commitment to tackle the challenge of NCDs. As you all likely know, SDG 3.4 states that countries should reduce by 1/3 premature mortality from NCDs. But progress has stagnated somewhat, and most countries are not on track for this. So even before the COVID pandemic, in fact, only 14 countries are on track to meet this target long term. Moving on to the next slide here. To combat this trend, over the last 10 years, the WHO has released a number of technical guidance documents to support integration of NCD service delivery. This includes the PEN package and HEARTS guidance. And it's also offered frameworks to strengthen data systems for NCDs. And really, a lot of this came together with the NCD facility-based monitoring guidance that was shared in November of 2022. Not only does this guidance propose 22 core indicators and 59 optional indicators to monitor primary care interventions for NCDs, but it also emphasizes the importance of digital tools to collect longitudinal patient indicators, which are especially important for long-term management of chronic NCD conditions. So this expert review has also really fundamentally highlighted that routine data for monitoring are an essential component for tackling NCDs, alongside other key parts such as registries, surveys, and improving governance and policy structures. So that brings us to today's discussion and where this has all started. So from a landscape analysis of the HIS Center, we've seen that at least 30 countries have integrated NCD data into their national HMIS system. And to support this further, we wanted to first undertake some rapid NCD data review of a select country HMIS. And let's see what's out there and what the data gaps are, and really use that as a springboard to improve NCD quality and data use. So with that, I'll move on to our first presenter, Seed Hussein from HISP Ethiopia. Seed, if you're there and wouldn't mind sharing your slides, that'd be great. Thanks.
Just attempting to make Seed a co-host now. He was not one yet. Stand by, please. Okay, Seed, you should be able now. Thank you.
Thank you, everybody. My name is Said Hussein. I'm leading HISP Ethiopia. We have been supporting the Ministry of Health here for the past 7 years in customizing, implementing, capacity building, and other activities of DHIS2. Since then, we have been integrated within the ministry. HISP Ethiopia itself as an office was organized in 2023. So it's a fairly young organization. In my presentation today, I will try to cover what kind of data we are collecting in Ethiopia regarding NCDs. So my presentation will cover, give you some background, will tell you about what kind of indicators we have, what kind of HMIS strategy Ethiopia is following, what data is currently being collected. As Brian mentioned, there is a kind of trend going on all over the world. We'll try to mention that, and how NCD data is being covered in other systems, health systems, and what kind of challenge we have, and we have some conclusion, and if we have time, we can give you some kind of demo about the system. So Ethiopia, like any other developed country, is going through this transition Brian talked about. This is demonstrated in the high number of communicable diseases and the kind of attention it's getting nowadays. In the WHO's NCD Progress Monitor 2022 reported that 43% of deaths in Ethiopia is coming from NCDs, and 70% of the plurality of premature mortality is coming from NCDs again. This is the WHO study released in 2022. There are other studies showing that more and more diseases are coming from NCDs than the communicable diseases. So on the other hand, this is being shown that NCD is currently highest in the urban areas than rural, but even in the rural areas, the impact is being seen. The program Ethiopia has a goal of promoting healthy lifestyles, reducing risk factors, provision of evidence-based clinical and public health interventions. As you can see here, it's more on the prevention side. It's focusing on the prevention side, changing lifestyle, reducing risk factors. The diseases they are focusing on include cardiovascular diseases, diabetes, chronic respiratory diseases, cancer, eye health, and other major initiatives. The objectives of this initiative is focused on 5 major things. One is strengthening capacity across the board. The second one is reducing modifiable risk factors. The third one is strengthening and reorienting health system to tackle NCDs. And the other one is strengthening surveillance and research. And at last, promotion of international cooperation and advocacy are to be used as strategy to tackle the NCD problem. Here, as you can see, there is a strong focus on surveillance and research. That's where the data comes in. The focus on PD-oriented indicators has increased because of this, along with the disease burden. The indicator reference guide the ministry has governs the indicators that are generated from the routine data collection systems, all the way to the community level facilities, from community level facilities all the way to referral hospitals. If you see, if you go back, like the second last indicator revision in 2018, only 3 indicators were available for NCD, focusing on cervical cancer screening, treatment of survival lesions, and cataract operations. The other indicators, though some of the data was being collected, but they were not given focus and they were not being highlighted. But in 2021, the 2021 revision, considerable focus was given for NCDs with 10 indicators focusing on hypertension, cardiovascular disease, diabetes, cervical cancer, and cataract have been added. This is on the indicator side. If we give you some background about Ethiopian HMIS, Ethiopia follows an integrated HMIS strategy. Previously, we used to have vertical fragmented reporting systems run by programs and partners. This was creating a lot of problems with data quality problems, the same data being reported with different figures with different partners in different programs. So vertical reporting systems were avoided in the new strategy, with all data coming from the facilities via the routine health service delivery forms. We have only 1 service delivery forms that are very long, like 40, 50 pages. But when we designed them into DHIS, we have tried to cut them into pieces and focus on other programs, even though it's coming through 1 department within the health facility. All this data is currently being recorded by health information technicians, HITs. They are one of the health workforce. They are counted as part of the health workforce. So they are trained at TVETs, these technical and vocational schools. They are trained on how to collect health data, how to interpret health data, and how to do some quality analysis and reporting. So this has helped eliminate fragmentation of reporting systems and promoted unified HMIS rather than program-focused systems. Currently, as I said earlier, we have 10 indicators, but these 10 indicators, when we come to the actual data collected, we have about 29 of them. Regarding hypertension, we have screening data. We have 2 data elements, one segregated by agent 6, the other one by result. We have treatment data being collected by agent 6, by treatment type, and by enrollment type. We have number of cohorts, those enrolled to care 6 months prior. The government wants to follow if the treatment is successful or not. And we have treatment outcomes as well. The same with cardiovascular diseases. We have data about high-risk individuals by risk category and agent 6. The other one, we have treatment by type of treatment and agent 6 again. When it comes to diabetes, we have screening, treatment by agent 6, diabetic type, treatment type, enrollment type, number of cohort like hypertension, and treatment outcome. We have on the other hand cervical cancer, again on screening, treatment, and outcome, and we have cataract, surgeries performed. Even the indicator is the total number of surgeries performed across the country. So if you see here, the focus goes through all the workflows. The focus is on screening, trying to identify how many people are affected by these NCDs. And there is a kind of data quality check going on between the agent sex distribution and the result distribution, and sometimes when it comes to treatment enrollment time as well. The government wants to track if every screened and identified case is treated, and the outcome is followed using the cohort system. This is an example of how the data is collected. As you can see here, NCD is being collected along with the malaria and NTD form. We have a malaria, NTD, and NCD form. As you can see, we have three kinds of data sets. One is focused on only health post. This is the community level data. The community level data, this one, health posts. I'm sorry, I have to go back. The health post is community level data. The focus here is only on screening. The health extension workers here who go house to house and screen every member of the household if they have any risk for cardiovascular, hypertension, or diabetes mellitus, or many type of cancers. And whenever they identify them, they refer them to the health centers, which are the next level. So the health center, the hospitals, and the clinics have another form. They focus not only on screening, but they all focus on also the treatment and cohort follow-up. Another one, we have a new kind of facility being introduced in 2023. That is an elevated type of health post that not only performs community services, but also some treatment services like health centers. So they have a mix of services for health post and health center. So this is the way the data is collected. As you can see here, whenever data is collected, it highlights if there is any data quality issue in red. For instance, here it's supposed to be the individual screening by agent sex has to be equal to by result of screening. If these two numbers are not the same, this highlighted data quality issue is always there. Whenever, for instance, here, if the result by type of screening comes with 54, this message will disappear. The other type of data Ethiopia collects regarding NCD is the morbidity and mortality data. We have a unified version of ICD-11. We have modified it for Ethiopian context. It collects data about both morbidity and mortality. It collects about 2,525 plus diseases. All the data here is disaggregated by age and sex. We have 6 age groups, sex plus there is the disaggregation of morbidity and mortality through attribute option combos, and we have treatment modality as well, where the service is given, even though if it's a days or caves, if it's at the outpatient clinic or inpatient clinic, that data is captured that way. On top of the national priority diseases, as we said in the service delivery form, like hypertension, diabetes, cardiovascular disease, cervical cancer, and cataract. Here, more diseases are given emphasis as well. Asthma, breast cancer, eye health, other types of cancer are also highlighted. We have a specialized module, a specialized application to collect data for these 2,500 plus diseases. As you can see, we are collecting data only when there is a case or a disease happening at the facility. So these data then are analyzed using a custom dataset report form, which I will demo later. So when it comes to other systems beyond DHIS2, there are AMRs at different health facilities, both private and public. They are starting to use the Ethiopian simplified version of ICD-11 to collect diagnosis and treatment data. But the implementation of these guidelines vary among hospitals. It's more implemented in public hospitals than private hospitals. Some of the private hospitals are using the full ICD level, but most of them are transitioning to the simplified version. And all this data is at the end of the month is aggregated and sent to the ministry for reporting purposes. At the lowest level, at the community level, as I showed, there is a routine service delivery data reported through DHIS2 that's aggregate, but the CHIS collects individual data concerning screening related activities. And mostly the activities here are the data is captured through clinical questionnaire. Sometimes they use some device like blood pressure monitor, but mostly the data is captured service given to clinical questionnaire, and the data is captured like that. Here there are questionnaires and algorithms to tell if a person has asthma, diabetes, hypertension, cardiovascular diseases, breast, cervical and prostate cancers, epilepsy, and eye health. So the CHS has about 19 packages, including antenatal care, child health, WASH, and one of the packages is focused on NCDs. But all this is not without challenges. Data quality is still a challenge in the country. Errors are happening when data is being captured on the registries and the registers at the facilities, when they are tallied from these registers and added, and then when they are returned into DHS. And some evidence shows that there are some edits after the data is recovered as well. Some of these issues are being identified and tackled by supportive supervision, but still the problem remains. The other big problem is data use practice is low. Maybe one of the reasons the data quality is low as well. When they start using the data, they can identify that it has some issues, and they can rectify the problem and start improve the quality and start using the data. Until the current version of DHIS for upgrades, we didn't have standardized dashboards dedicated for NCDs. We have some visualizations based on the indicators identified, but they are not standardized using the protocols prepared by the ministry and shared across to all health workers using DHIS. But in the current finalized version of the upgrade cycle, which we finished this past 2 months, we have standardized dashboards focusing on NCD as part of the other customization attempts. As a conclusion, we can say that routine service collects only a few NCDs. Still, NCDs, there may be a need to focus on other NCDs as well, like asthma. But the focus whenever we are selecting in Ethiopia for selecting indicators is we have to follow these 4 rules. It has to be standardized across all facilities and across all partners. The name of and the definition of an indicator has to be understood by everybody. It has to be simplified. It has to be integrated with the system as well, and it has to be institutionalized. When you say institutionalized, we have to have the tools at the facility to capture the data from the patient cards into registers, tally sheets, and all. So unless we have all these tools in place, all these considerations in place, indicator is not selected and integrated in the national system. But in every revision cycle, there are requests to add more data elements and indicators. But NCD is one of the areas given focus in the last cycle of indicator revision. Morbidity and mortality disease list differs by type of facility. Another highlight is The community level is expected to collect data about only 94 diseases. Among them, there are some identification of NCDs, but the application doesn't limit capturing data only for these 94 diseases, because the diagnostic capacity at, for instance, the health centers are expected to capture only 700 diseases, but if there is better diagnostic capacity there, they are allowed to capture data pertaining to NCDs or other diseases configured for hospitals. So it depends on the diagnostic capacity, the service provided, the number of staff. We have all these in consideration whenever we are reporting diseases. If you give me a time, I can give you some demo on the system. We have a sample system in local here. I can switch my screen. Can you see my screen?
Yes, we can see it.
Yeah, so this is a local version of DHIS2 with some tech data we configured for demonstration purposes. As you can see here now, we have this prefix HMIS 23 is to be removed when we release it down to the users. But as you can see here, we have some standardized dashboards pertaining to specific service delivery groups. So we have about 7 indicators configured here. Of course, users are allowed to configure more visualizations for themselves, and there are guidelines for that. So as you can see here, we have proportion of women screened for cervical cancer, treated for cervical lesion, and there is a cohort of blood pressure for hypertension, the blood pressure for diabetes again, CVD receiving treatment, number of cataract surgeries per million, and we have at last the visualization for mental illness as well, which is not highlighted as the other NCDs. To show you some how the data entry is going on for the disease, for instance. So as you can see here, we have the period. We have, by the way, we have our own data entry applications because our requirements are different from other countries. So you select departments if it's inpatient or outpatient, statistics is the inpatient outpatient department, either if it's a case or death. And once you select that, you have a row to capture data and new data about a disease. Here, all the 2,500, more than 2,500 diseases are here. You select the data you want to capture, and you can capture like that. You can type 1, type 2, you just capture, and when you select another disease, this row is pushed down. This application has helped us simplify the process, because capturing data for 2,500 diseases in a normal data entry application was very heavy, and it was not convenient for us. The way we analyze data is also different here. This is requested by the ministry to focus on top 10 diseases, top 10 diseases. So we have the department here. You can simplify by department. So if you say this last 12 months and generate a report, it will give you the disease incidence, the number of diseases occurred by facilities, ordering them.
See, we're running a bit out of time here. Thank you for the demo, but do you think you could look at some of the questions in the chat to wrap up in the next few minutes?
Okay. So let me. Are the tracer indicators directly adopted from the global DHIS metadata, or were they adopted from country level KPIs or measurement to DHIS? I think whenever they are whenever we are selecting indicators, there is a team of people that are proposing indicators, but the selection is done with partners, programs, and many people. There are many considerations given, and even international indicator alignment is considered as well. But at the end of the day, the national requirements are given more emphasis. I don't see other questions. Does your dashboard provide indicators at the facility level? Yes. These dashboards I tried to show, they are shared all the users with the analysis privilege. They can see the currently configured dashboards, or they can configure their own, which sometimes is the case. I see following items missing: childhood cancer plus. So childhood cancer in the disease and morbidity and mortality data, we have cancer, as you can see from the age disaggregations. We have starting from less than 1 all the way to plus 65. So if there is a disease occurrence in any age, it's captured. And if it fits that specific age group and sex. For instance, if it's scrotal cancer, women are avoided, just like that. If it's not applying to a specific age group, it's not avoided. I don't see any other questions. If you have more, I can entertain.
Thank you so much for the presentation, Seed. We can take more questions at the end if there's time.
Okay.
Next, we have JP Matali presenting from his Rwanda. JP, if you could kindly share your screen now to present your slides.
Thank you, Brian, and thank you, Said, for presentation. I'm Jean-Paul Mutari from his Rwanda. I'm going to make a short presentation about the NCD data in Rwanda. So I'm a system admin integration team at his Rwanda, and I'll be presenting this data with permission from the Ministry of Health. Rwanda faces a high burden of non-communicable diseases, and they account for more than 50% of all deaths. And the Ministry of Health monitored the NCD burden in Rwanda through indicators in the health information system based on DHIS2. The facilities and the community report both aggregate and individual case, or either on daily basis for individual data and for monthly data for aggregated data. And the data or the NCD cases vary by facility. So there are those which can be reported at the facility level or community level, and also go up to the hospital, and it's all done at public and public and private facilities. So the type of data being collected are three categories, if I may say. There are all type of NCD, but there's also part of prevention, which involves like a cancer screening and other like hypertension, diabetes screening, but also awareness campaign for prevention. So as I said, the level of reporting is the whole level of health care system in Rwanda, from the community up to the hospital, and they report either on daily basis or monthly, and so they cover all, either screening, diagnostic, treatment, and the awareness. And to ensure the data reported of the quality, normally the process involves data verification before sending the report for monthly data, and for individual level data. With DHIS2, there are so many controls which helps capture information within the allowed minimum the errors. And so from my screen here, you can see, for example, a screen where we do community screening, where the individual data is input, and then we can have the disaggregation by age, by sex, and or the number, or if the value is very high, then we know the person is a high risk of NCD. So the data quality approval and process involve the submission of data for monthly data in DHIS2, but there are a series of meetings to validate data from the point of collection up to the point of entry, and the data set is locked on 10th of the following month, and if you need to change, you need to ask permission or to verify why you are going to change this data. So the data currently in Rwanda HMIS system based on DHIS2 is used for decision making, and mainly for planning. These data are used mainly for resource allocation. As on the first page of my presentation said, the NCDs takes a huge chunk of death. So these days, most of the resources are now directed to prevention, but also to treatment. The other part is healthcare system management. There have been now specialized clinics which are being set up after analyzing all these trends of NCDs. The good example may be the Global Health Equity University, which is a cancer center of excellence, which also allows the enrollment of international students for this cancer center. And also, there are several community health initiatives. In Rwanda, every 2 weeks, there is in cities, major cities, there is a car free day on Sunday, where people come to exercise, but also to do NCD screening. The data also is used for international collaboration and the funding, where after getting all these data, these are presented to funders for collaboration, but also for research and innovation. So these are examples of dashboards which are produced within the DHIS2. For example, here we can see the top 10 cancer cases by country, and each user of this application can see the top cancers in their district or their facility by period. So this dashboard at the national level, they have a map of the whole country, and they can have cases total by gender, or they can do, because this is the individual data here, they can do by age or by any other criteria. So this is another example of a dashboard to monitor community screening. As I said, more emphasis has been done now on prevention. So each district has a target population of people who are older than 35 years of age, because those are the main people who can be can get NCDs. So those are screened by district, and they can monitor how many people they are screening for the whole fiscal year. And the graph here will be turning into green when they reach the target percentage, which is 85% for every year now. But there are still some gaps in the data utilization, where we not all data collected is currently being used, so there are still opportunities to explore the data being collected, and also the integration of different platforms. Maybe going to other systems which are used apart from the main HMIS. There is a cancer registry. This is also based on DHS2. There is NCD screening community, which is specifically for hypertension, diabetes. This is DHS2 as well. But there is an electronic medical records module for NCDs, which is used in health facilities. This currently is not integrated with any of these. There is a stock of trusted drugs, and there is a CRVS which has all deaths on individually. So these individual data collects patient data, and they are run like separately. So the cancer registry has only cancer data. The NCD tracker has other screening, and this EMR has now the follow-up of patients who are positive. So this is how the community screening flow is done currently, where in the community on car-free day, for example, or any other day that is, the facility has chosen for screening, they can go and enter individual information in DHS2, and DHS2 will inform whether the person is suspected of having either hypertension or diabetes, and if it's positive, they are then referred to hospital to confirm the case. And if the case is confirmed, that's when the patient is enrolled in the EMR for follow-up. So this is a community screening where they do screening and then they intake information DHS. The future plan now for using this information to combat NCDs are mostly capacity building for data use. There are a lot of data, as I said, there are individual data being collected, but not fully exploited. There is development of these data quality dashboards, and also the continuous integration of different systems. So in Rwanda, the HMIS collect these data, and there is also ongoing initiative to continue by individuals so that they can have all the details, and then it has data management. So I I will end by thanking the Peace Center of Vassavoso for facilitating the assessment that we did, and also the Rwanda Biomedical Center. Thank you.
Thanks very much for sharing, John Paul. I think we have a few questions in the chat if you want to take a look at those. First from Farshad, would you please let us know how did you calculate NCD screening coverage, since for hypertension, diabetes, and cervical cancer, all denominators are different? Paul, are you there for questions?
Yes, sorry, I was on mute. So how this calculation is made, this is just a calculation of how many people were screened for different disease, for hypertension, for diabetes. So we have a total number of people over 35 years of age, and the data now is inter-individual. So if a person is screened for hypertension, so we take that one. If the same person is screened for diabetes, it's not counted again. So it's number of people who are screened. We have other dashboard for specific disease, for hypertension alone, for diabetes alone, but that's the total number of people who've come for screening. Yeah, the screen I was sharing was only the total number of people, but we have specific for hypertension, for diabetes, for cancer. Yeah. Yeah, sure. We have, as I said, we have individual data. So we count by sex as well. So we know if it's a person is a male, so they are not even a screened. If you go to data entry, you will not see cervical cancer because it's male. It will be automatically hidden. So those will not be counted in the denominator.
Before we go to our next speaker, I think there was one more question from Tony above that. How did you decide on indicators for the NCD program? Any specific interventions you can mention that were supported by tracker indicators? Supported by tracked indicators.
Yes, as I said, one of the specific intervention I mentioned was the setup of Cancer Center of Excellence, which is at the university as well. So that one was set up after finding out that now cancer is one of the highest cause of mortality. And after that, this center was established and turned into a university so that they can handle this. This one of the option or the results of these tracking of this prevention cancer. But also there are also other community awareness activities, which are results of that. As it's mentioned, there is like a community screening, which I showed the dashboard, where everyone above 35 years age is targeted for screening.
Great. Thanks, JP. Next, since we're moving from east to west, we'll be going to Malawi with Gift and Noel. I'm not sure if they could please share their screens to start with the next presentation. Over. And if you have any more questions for JP, please leave them in the chat, and then we can get back to them at the end if we have time.
Noah, I think Noah is supposed to take the presentation. Yeah.
Right. Thank you very much. Welcome all the way up. So I'm going to present the landscape for NCDs in Malawi. This has been work that we've been doing together with different partners. But then, so I just wanted to explain that in the introductory, we have many key players that have helped us in coming up with the data. We have been working with East Malawi, the UNIMA team, just to see how best this would work out. Trying to move to the next. All right, thank you. I think so. As a vision, we're looking to improve quality of life for people through reduced mobility and premature mortality, and promote better health. Part of our mandate is strategic leadership, program operations, service provision, coordination, resource. This is just a snapshot pertaining to the burden of NCDs in Malawi. Currently, they account for 32% of that in Malawi. But from the WHO report that we just had 2023, it shows down there on the cardiovascular conditions, hypertension.
Noah, you are happy audible. I don't know whether people on the call can hear him properly.
Okay, maybe is that okay now?
Yes, and
That's
maybe
much
I
better.
think,
Thank you.
yeah.
All right, thank you very much. All right, so I was just talking about the burden of NCDs in Malawi, and I said they account for about 32% of deaths in Malawi, and 40% of deaths are contributed by NCD versus the communicable diseases. And the cardiovascular conditions, you have hypertension is at 16.1 to 32. These are figures that are coming from the STEP survey 2009 and 2017, and general cardiovascular at 8.9. Our chronic respiratory is at 5.1 for asthmas, and cancers contribute 16% of NCD deaths. Our diabetes is at 1.6 to 6%, with accidents at 3.5. And I just wanted to show you the trends of hypertension of all the conditions that we are currently tracking in our NCD in the DHIS2. This is excluding the pen plus. And currently we have figures around 30,000. And this is, we have around, 30,000 plus. But then these figures are just showing what is in the districts and the selected health facilities. We'll explain more on this graph as I continue the presentation. what have we done on data management efforts? So currently in Malawi, we have facility level data, which is a paper-based NCD register. And then we do have the Yendanafe, which is being implemented in NENO by Partners in Health. And then we have the hypertension and diabetes EMR. This is being supported by Diabetes Campus, where we're trying now to get most of this information digitally done. So this is an ongoing work and the aggregated data sets. Pertaining to patient management, we usually use the NCD MasterCards as they have the continuum of care for all NCD clients since enrollment and their course of life. At the community level, we have the IQ's NCD module, which is being developed. And currently, we are finalizing the screening protocols for hypertension and diabetes. This is the starting point, and we hope we can add it in the module as time goes by other screening conditions. Within the HMIS, or should I say the DHIS2, we do have the 10 plus facility monthly reporting form, and we do have also the quarterly reporting form. This is just an example of the NCD module in the IQs. These are some of the information that we look for. There's the household register, person register, and then you have now the non-communicable disease, and now we are also looking into the NCD palliative. So we are trying to align most of the work that we're doing also to the palliative program. And pertaining to screening, these are some of the questions, these are some of the work that we're looking into. So we do have the screening questions for hypertension, diabetes, depression, and schizophrenia. So this is just a start. That's what we've been working on with UNIMA for the past year, together with CMET, and we're hoping to be concluding this and rolling out later on next year in 2024, 2025. And this is just a snapshot of the indicators. It's not exhaustive, but just to appreciate what we have. At national level, we do have the road traffic accident mortality, the suicide prevention, and at program level, we look at the NCD in road and on treatment. And then we do also have the 10 plus, where we look into congenital heart disease, the rheumatic heart disease, sickle cell, type 1 and type 2 diabetes. And we're also looking at the rheumatic heart disease. So this is just selected indicators that we're tracking. There are more, but then I think we can always discuss later on. Okay. So I just wanted to give you a snapshot on the reporting rates currently in the DHIS2. On my left-hand side, you have the quarterly reporting form, and at least 60% of the districts are actually reporting on completeness, timeliness, and we're now looking into how to address the other districts that are doing well. Some of the challenges, I will explain them as we proceed to the other slides. On my right-hand side is the 10 plus. For the 10 plus, we have to exclude Mango, we have to exclude Kasungu and Chenji, and they're yet to roll out. But then the rest of the districts, Karonga, Mangochi, Neno, Chisi, Rumpi, and Salima, these are the districts that we have now established 10 plus. And we're looking forward to scaling up. We just got some funds from WHO Afro, and we'll be working with the country office on how we're going to scale up and reach facilities. So a number of reporting facilities will increase. Including that, we do also have the WDF, the World Diabetes Foundation, that will be scaling up in 3 more districts too. And we're hoping that with the Scottish grant that we've got, will be managed also to scale up the 10 plus services to 4 districts. So we're looking forward to actually now finalizing some of the work on the 10 plus, including the contract with the WHO pen by mid next year to ensure that all these are aligned and we're having data interoperability. I will move on to the data and capacity gaps. So this is where I said I would dwell much in. So data collection gaps, we have that both in tools and the important facilities. as the current data we have is coming from district hospitals and selected health facilities, which means for Malawi we still underreported. And then we have also the private hospitals and the Christian health child facilities that also haven't yet started reporting. So I believe we are yet to define the NCD burden apart from the state service. So we still have a long way to go, and we're looking forward as Ministry of Health to ensure that we align as we try to strengthen the public institutions. On our mind, we're already thinking about what about the other institutions that are providing the services. And pertaining to inadequate screening and data tools at community level, we use the word inadequate because currently we're only screening for hypertension and diabetes within the NCD program. I know cervical cancer is being screened and monitored through the reproductive health department. So other conditions are the ones that we can whereby we like to have a very robust screening program for Malawi. But then now we have managed to train over 9,000 health surveillance assistants, and they have been equipped with concomitants and BD cups, and they are able to do the screening with the communities. However, they are using rapid this those related to that we use, but we haven't yet linked it to the THIS. So this is an area that we are trying to look into this particular conversation. And we have the alignment of national indicators set by the WHO.
No, Noah, could you try speaking a bit closer to the microphone? It's a bit hard to hear you again.
Okay, so I was saying that the alignment of the national level indicators with the global standardized indicators, it was said that by the WHO is incomplete, but the process has started, and we're looking forward to finalizing the work. And as I said, the linkage between the community level data that is being collected now has to be linked to the DHIS2. January to May, we have managed to comprehensively review the metadata and review the WHO indicator handle. So we have revisions to the handle. We managed to hold a workshop where we managed to revise the indicators and selected indicators that are prioritized for national level monitoring on the dashboard, and managed to also see which ones are the problematical. And then full presentation on the organization of the so how this work, the work that we're doing with HMIS Malawi, just to ensure that we have got the backing, we have the stepping platform. So thank you very much, I think, to the team that managed to organize this, because we realized the gaps that we're having, and this was co-chaired by the
No, you are happy audible.
All right. Is that okay now?
That's much better.
Okay, all right. Thank you very much. So, as I said, we commenced the development of an interoperability module with facility level EMR, and we have been working sessions with World Diabetes Foundations towards incorporation of other service monitoring indicators and extension of HMIS reporting tools to accommodate the new indicator needs. And as I had said, most of the work is being done partners, but I would like to recognize also UNIMA coming in to have the comprehensive review of the metadata and also working to align to the WHO indicator framework NCDs. So this is just part of the events that we have done for Pen Plus, the M&D Pen Plus. It was led by UNIMA and CMED. And we chose to have the data field review and global indicator alignment. This is supported by UNIMA And this took 3 days, and we managed to get the done. So we planned so validates the dashboards.
You're breaking again. Noah, you're breaking.
Managed to is that better now?
Not too clear. I don't know the other people, but you're not too clear.
Yeah, it's not very clear. Can I suggest you move closer
So,
to the microphone? But we have a couple slides left, so let's go through it.
Yeah, okay. Let's see. Is that clear? Is that better now? I'm now talking on top of my voice. Okay, so they have managed to build the capacity of the NCD division of the data quality. So we targeted the NCD coordinators and the data clerks and the HMIS officers, and we're extending the HMIS reporting forms to address the identified gaps and align with other initiatives. Working on integrating the community health information system into the national HMIS. We have also worked on interoperability of ITs with the facility level MR, revised the ITs NCD tools in light of the new requirements, progressive rollout of ITs NCD module will be done in the next few months. So then that's the end of my slides. Thank you. Apologies that maybe something is wrong with my mic. Thank you very much.
maybe just to come in on the areas that he wasn't audible. I think on the areas where on the planned activities. So after the activities that we conducted with the NCD review project that we had, we also looked at the WHO global standardized indicators for NCDs, and we aligned them with the national program level indicators that were configured for the program. So we also looked at the indicators that were there already on the HMIS, and the ones that the ministry needs but are not there yet. So we aligned with the current national efforts to also look at which indicators can we adopt from the WHO standardized indicators for NCDs and for other programs as well. So you would look at cancer programs, the hypertension programs, the diabetes programs as well. So I think in the next phase for this implementation, we're going to align what is also on the community level with what is at the facility level, and also push this data into the HMIS for overall decision making. So basically, I think for the last slide that he was presenting, that's what we are going to be doing. So there will be that validation of the NCD dashboards. So we started with reviewing which indicators we want to include in the national NCD dashboards. So the indicators have been mapped. We are yet to configure those dashboards as well in the HMIS. So yeah, I think I just wanted to add on that one. Thank you. I think now you can stop sharing.
Yeah. Thank you, Gift and Noel, for the presentations. Are there any additional questions before we move to our last speaker today? You can raise your hands or enter into the chat. I see a question from Hanan Khalil earlier. Maybe it was already addressed, but has there been an evaluation of the system against a gold standard or survey? Maybe some data triangulation against population health surveys. Gift, Noel, do you want to answer that?
Sorry, can you come again? Sorry.
There was a question in the chat. Has there been an evaluation of your system against gold standard or survey? Possibly comparing with population level health surveys or with other indicator lists?
Yes, I think there has been, so through CMED, there are a couple of surveys that are conducted within CMED. So there's been a couple of them. And also there's this routine review of population data that's pushed in the DHIS2 against the data that we are collecting. Yes.
Thank you. If there are any more questions, enter them into the chat and we'll try to get to them towards the end of our last presentation here. Again, Oswald there for our last presentation from Ghana. Oswald, you're good to go. Thank you for sharing your screen.
Can you see my screen?
Can you see your screen?
Okay. Good afternoon. My name is Oswald. I'm presenting on behalf of HIPS Ghana. So by way of a little background, we all do know that NCDs are becoming a major cause of mortality in sub-Saharan Africa, particularly, and to develop targets and make decisions that are evidence-based towards reducing the burden of NCDs in the world. For Ghana as a sub-Saharan, the burden of the disease, especially in Ghana, about 13% of Ghana's population, according to data from the Ghana Health Service and the WHO in 2022. Affected by cardiovascular disease. About 6.3% of the population is also affected. And then about 24,000 new cancer cases are recorded annual of NCDs that we have as a country. And it is important to ensure that we are able to measure the full use, the burden it has on our economy and then our health profile as a country. When it comes to the project, what we aim to do was to try to improve the accuracy and use of NCD data within Ghana's health information management system. And so as way of objectives, what we did was to do a rapid assessment of NCD data that is available routinely in Ghana. So we evaluated all the data sets that were in the national HMIS that is DIMS 2. And also that existed, and also try to see what baseline understanding of the data scope and integrations we can recommend going forward in an effort to consolidate all NCD related data that is available in country. We were also targeting to do some training of our HMIS officers across them going forward. Now, by way of methodology, what we did, as I indicated, was to do an inventory of all the data sets, and after that, we identified the gaps that are currently in existence, and also looked at the individual level data that is available on some systems across the country, and then possibilities of integration. What were our key findings when it comes to data availability? Generally, Ghana's HMI capture data at the facility level, and we have in the country that reporting to the national HMIS, and it is a mix from teaching hospitals right to health centers and hospitals, and then community level clinics and what we call chip zones. Then we also do have a mix of reporting of data into the HMIS system that includes non-communicable disease. When it comes to that, the national HMIS had a host of data sets that contained NCD data. Notably, it's what we call the monthly OPD mobility returns that records new cases of all diseases that are diagnosed at OPD level. And so they have a data set that is submitted on monthly basis by every facility that is reported into the national HMI section on non-communicable diseases, as you can see on the inset here, that deals with hypertension and all other popular NCDs in there. We also, through the inventory, found out that the country have recently deployed new NCDs only that will deal with NCD screening at the facility level and also NCD diagnosis. That is trying to give a lot more detailed capture of data when it comes to NCDs, apart from what we have on the monthly OPD mobility reporting form. When it comes to data completeness for aggregate data, it isn't very bad. For the OPD mobility data set, it's 99% completeness and 10 years for the country. And so that is the major source of NCD data on the national HMIS. The new custom ones, that is the NCD specific data set for mobility and also for screening, were only developed somewhere in 2022. And these are not fully deployed across the country yet. And so it's averaging around 5% at the time of. Regards to event-based data, what we found out was that the country also have what is called an event instance that deals with inpatient mobility line listing that captures key demographic information of clinical tests of clients that are admitted into the extensive information about NCDs. And so that is one of, apart from the OPD mobility data, event-based data, one of the huge data sets that the country have is the event-based instance that contains NCD data. And this dates back to 2014. And so that is also about 10 years of NCD data that is available for use across the country. Then we also noted that there have recently been some pilot deployments with NCD tracker for trying to set up an NCD registry for hypertension, diabetes, and then some childhood cancers. That is being piloted by a project called the Ghana Heart Initiative in some coastal communities in the Greater Accra region of Ghana. And then also within the Ghana Health Service, there is a program called the National Non-Communicable Disease Program within the Ghana Health Service setup. And so there is also a pilot at that level that is trying to move from aggregate data into capturing NCD data using the tracker instance, as Ghana have extensive implementation when it comes to tracker across the country. So that was also with regards to event-based data. What we found out was that it is a key thing to deal with of the data, because and as a major source, one of the discrepancies we noted was that as a country, the lower level facilities, that is chip zones and clinics, are being discouraged from diagnosing non-communicable diseases as they may not. That is one of the things that we identified, and also some inconsistencies in reporting when it comes to the private facilities, as not all private facilities currently report into the national HMI. So there is some level of gap when it comes to data availability on it, especially from the private, and then the very lower health facilities as chip zones. Lack of national deployment of the new NCD specific data sets that have recently been developed is also one of the gaps we identified. Was had to do with data integration and trying to create synergies, because the country currently is deploying an EMR for all teaching hospitals, regional hospitals, and hospitals that is containing clients, and this is not currently integrated to some extent with the national HMIS, which is the INS2. And so we think that it is one of the groundbreaking things that we can do to be able to pull line listed client data into the national HMI, so that we can begin to match that with what we have on the aggregate data set to be able to initiate triangulation attempts and then improve our data capture and all that. Then the other thing we think we can improve on has to do with linkages with reporting linked with international surveys to try to do some comparison. So it's one of the areas we think once we get all our data integrated and pushed into the national HMIS, that can be then be triangulated with a demographic health survey results for the country, and also the dashboard on the institute to improve data use and all that. For the future, we think that the EMR and the event-based instance of the Ghana Health Service is one key area that can be dealt with. And then also the NCD tracker package that is being piloted can be enhanced and expanded to all NCD clinics and hospitals. And then we can be able to then improve on record management and real-time access for all clients that attend facilities in Ghana. As a conclusion, we think that we can improve data accuracy and usability if we are able to sources of NCD data into the capacity of the health staff. Ghana has CEST, then also the district level, and in some instances, facilities have HMIS offices. And so we think if we build their capacity to be able to do some analysis with what data already exists in the national HMIS, it would encourage CDs, and thereby improving the use of data that is already existing on our system. And then, of course, we want to be able to continue efforts to train personnel and also improve on consolidation of the systems that already exist, as we learn from other countries, to be able to have a holistic picture of NCDs in Ghana as a whole. Thank you.
Thank you, Oswald. Do we have any questions for our last speaker, or any questions for the broader group, as we have about 5 minutes before close here? Rashad, I see your hand is up. Not sure if you can unmute. Ellen, could you unmute Farshad?
Working on it now.
Hi, good afternoon. Thank you so much. I appreciate that. That was very, very exciting, experience of the digitalization at the facility level. There is no question, just one comment that we are going to, sorry, I'm Farshad Farzad. I'm a scientist in World Health Organization, working in NCD department in WHO headquarters. The news is that we are going to be next week in Ghana to implement the end user testing on the platform that has been developed by the colleagues in the system and going to be used by Ministry of Health to evaluate the level of the flow of data and also flow of patient compatibility with the indicators and so on. And also one item that we are going to check, and I'm encouraging all is to think about this, is about the dashboard that would be very practical for the people who are working at the facility. For example, I know I've been in Ethiopia several times, and I saw that they have targets at the facility level, which is wonderful, but it is on the paper and it is not easy to be followed by people who are working at the facility as a health professional. And probably the health information officer, yes, but for health professional like physician or physician assistant or midwives are not easy to handle this data as a daily practice. Brian, probably in one of the meetings possible, it would be great for us to have a chance to present also the new dashboard that we developed. We call it Action Plan Developer, that helping people in the facility to compare their results easily with the results that achieved by the other facilities or at the district level or other facilities within their own province level, and to be able to improve the system. And because we call it Action Plan Developer, because we are also suggesting some interventions to improve the indicator when it comes, in the level that it is not desirable. So I will stop here. Thank you so much, and hopefully we can provide some feedbacks about the both initiatives that we have. One is end user testing, that we had the experience first in Ethiopia in close collaboration with Result to Save Life, and now we are doing it in Ghana. And also the second thing is Action Plan Developer. Thank you so much, Brian, for the time that you provided me.
Thank you very much, Farshad, for the comment. I look forward to hearing more about those initiatives, and hopefully we can collaborate both with the HISP Center and other HISPs on learning more about them and putting them through country implementations. I think it also connects to Nora's comment that she dropped into the chat as well, that in general, NCD data is needed for both public health and patient care, and sometimes we might be conflating the two. And same with performance dashboards as well at the facility level. They need to both track individual patients and also understand the NCD dynamics at a local level and compare them with other groups. We also have a question from Michael here as well for Oswald. I'll just read it out now. It's the quickest. Oswald, if you wouldn't mind sharing, are you working towards disaggregating the data, the NCD data in Ghana already? It seems like it's mostly aggregates at the moment. So maybe that means either line lists or disaggregating by categories.
Yes, so there is already some work going on to disaggregate. What we have aggregate is already disaggregated by sex and age, but there is some tracker we're going on to have it in granular form beyond the event-based data set that we have available. There's some work going on already with tracker data on NCD. Thank you.
Thank you for the response. Are there any other questions before we wrap up here? Good point, Nora. There's unfortunately not much more time to discuss about the general data quality concerns and also use of NCD data. But that's one reason why we wanted to do these assessments to see what's already ongoing and then start planning some strategies. So that's a good next step that we can take for another time. But that's about all the time we have now. I just want to give one more round of thanks for our presenters today, Seed, JP, Gift, Noel, and Oswald, as well as our sponsors at NORAD for making this webinar possible. I hope you all have a great day, and thank you for your for very interesting questions and your collaboration in this. So take care all, and have a great afternoon.